Welcome to the Best Practice Guidelines BPG Champions module. This presentation was developed collaboratively between RNAO, Registered Nursing Association of Ontario, and the QBPRA team on behalf of VHA Home HealthCare. Following this presentation, you will be asked to complete a quiz to demonstrate your understanding of what it means to be a BPG champion. The objectives of this module are threefold. 1. Learn about best practice guidelines, BPGs, and the important role a best practice champion plays in implementing, evaluating, and sustaining guidelines. 2. Learn about the processes of BPG implementation and how they benefit your work and your organization. And 3. Identify opportunities, strategies, possible challenges, and facilitators to guideline implementation. At the end of this module, we hope that you get a sense of what it means to be a champion of best practice and to reflect on your own clinical portfolios at VHA to continuously champion positive change. Let's start with the basics. So what are BPGs? Best practice guidelines are systematically developed statements to assist practitioner and client decisions about appropriate healthcare for specific clinical or practice circumstances. In other words, or in simpler terms, BPGs are evidence-based documents that were developed by expert panels through research that provide guidance and recommendations for a specific clinical topic area, used to promote optimal care for clients and to maintain a quality of the service professionals like yourself would provide. But remember, BPGs are general guides and are not intended to be the end-all, be-all. Healthcare decisions in specific clinical practice situations should still depend on a nurse or regulated health provider's clinical knowledge, skill, and judgment, as well as respect the client's preferences in care planning. This means the provider still needs to use their critical thinking and decision-making. The purpose of BPGs can assist with any of the following, for example, assisting with clinical decision-making or stopping interventions that have little effect or cause harm. Let me give you a few scenarios. For example, the BPG for stroke assessment across the continuum may recommend that a complete nutrition and hydration screen be done within 48 hours after client admission, whether to a long-term care facility, hospital, or home care organization such as VHA. This recommendation pulls data gathered through evidence-based research and translates it into the clinical practice of day-to-day, as well as reducing variation across organizations for when a nutritional assessment should be done for stroke clients. Another example would be the BPG for pressure injuries. It recommends obtaining a wound culture by cleansing with normal saline first, then swabbing the wound bed, excluding the eschar, slaw, exudate, or wound edges. This recommendation assists in the clinical decision-making of frontline practitioners and conveys the knowledge base specific to nursing. Can you see the purpose of BPGs now? They serve to make us more accountable for client safety. In summary, RNAO best practice guidelines provide recommendations around a clinical topic for practice, education, and organization and policy. Simply stated, incorporating evidence-based practice means putting the evidence into practice. So now you might be thinking, this is all great information, but why am I here? What does it mean to be a champion? That's a great question to ask. The definition of a BPG champion is someone who sustains a campaign for a new product line or change. That's where you come in, you're a change manager. Is characterized by a conviction that there is a better way of implementing, believes in an idea, will not take no for an answer, is undaunted by rebuffs, and above all, persists. Champions are opinion leaders, facilitators, change agents, explorers, clinicians, promoters, campaigners, knowledge brokers, disseminators of evidence, clinical advocates, practice experts, or all of the above. Remember, change isn't easy. Anytime change is proposed, people want to know why it's needed before they'll support it. That's why clearly communicating the rationale for the shift in practice is critical to initiating change. How? Champions assist with knowledge transfer, promote the uptake of best practices, share resources, are experts in sustaining the change. Champions are change leaders. You have a very important role to play. Let's move on to the next section. How do BPGs get implemented? Because implementation means change, there are several initial questions to consider before BPG can even be considered, such as, Does the BPG apply to the whole organization? For example, if VHA was choosing to implement the delirium, dementia, and depression DDD's BPG, should we implement across the organization, across all regions, across all providers, including providers in the Child and Family Program? Dementia may not apply to the pediatric population, but the clinical topic of depression may be just as important for young individuals as it is for older adults. Are there specific recommendations that fit with known organizational needs? For example, if VHA implemented the delirium, dementia, and depression BPG, does this align with the organization's strategic direction on cognitive impairment and the organization's vision, mission, and values? Are some recommendations better supported by research than others? Are some changes complex, expensive, and/or take time? At VHA, we must consider the time, priority, budget, and resources before any macro change in practice can be considered. Should some processes and organizational changes be made first? For example, if we were implementing the BPG on person and family-centered care, does the culture of the organization need to change first, or will it change with BPG implementation? And finally, are guideline recommendations already in place or partially in place? Has work already been done in relation to a specific BPG? This will determine how much work really the implementation process needs to take place. Let's go over briefly the process of BPG implementation. Step 1, gap analysis. A gap analysis is an examination of whether there are gaps between current practice and best practice, and where and to what extent these gaps exist. The purpose of a gap analysis are threefold. To identify opportunities for early success. This means focusing on moving the partially met or partially in place recommendations and practices to met categories. This can give you a very quick win. Identify bright spots within the organization. These are all the right and great best practices the organization is already doing, without actually doing anything. Identify practice change direction, performing a future analysis of what changes you are going to make to align with best practice, and this progress can be measured over time. Remember, a gap analysis also determines whether an organization is ready for change. For example, is there infrastructure such as staff mix, committee structures, staff competencies, equipment, resources, policies and procedures, role descriptions, and internal or external funding? Are there human resources such as leadership at all levels, communication, collaboration, congruence with organization's beliefs, vision, and mission? These are all variables that could affect change implementation. Step 2, stakeholder engagement. Stakeholders are individuals, groups, and/or organizations with a vested interest in the decision to implement a BPG, or one who will be directly or indirectly affected by the implementation. There are three types of stakeholders: internal, external, and interface. Internal stakeholders are those from within an organization, such as staff or unions or committees. External, as the name implies, are those outside the organization, such as accreditation bodies, consultants, or professional bodies, such as the College of Nurses of Ontario. Interface stakeholders are those who operate across organization and environmental boundaries, for example, staff with cross appointments between organizations. The purpose of stakeholder engagement is to align their interests to initiative goals, to gain greater acceptance of your proposed change, and to anticipate and address objections and resistance early. Remember, objections or resistance from stakeholders can be a normal part of a change process. Once stakeholders have been identified, each person or group's degree of support can be determined. They can either be supportive, non-supportive, or indifferent to the BPG change initiative. It's imperative to reflect on an important question at this point of the module, and that is, why would stakeholders want to be engaged? Or an even better question, since a BPG champion are stakeholders too, why would you want to be engaged for BPG implementation? There can be many reasons. For example, a personal one, such as a stakeholder is looking for promotion, so looking for different opportunities for change. Could be a professional reason, such as the stakeholder is an advocate of best practice and client safety, and wants opportunities to be professionally involved in a culture change. Stakeholders may also want to be engaged because of personal interest related to a specific topic. For example, Jessica may want to be a champion of change related to stroke management because a family member may have experienced it and they received less than optimal evidence-based care. Or stakeholders may want to be engaged due to reasons such as workload. For example, Catherine may want to be involved in championing the pain best practice guideline because the new documentation can reduce the number of forms from 10 to 2. Different stakeholders may be engaged in change for different reasons or multiple reasons. These are some strategies to ensure successful stakeholder engagement. Successful buy-in requires creating trusting relationships between colleagues, but also between the senior management, middle management, and frontline providers. Making sure everybody knows what's in it for them. Being prepared for ongoing negotiation and adaptation. Active listening to everybody involved and considering their points of view. Understanding some stakeholders will reject change attempts, and this is normal. Knowing change does not happen all at once and requires time. Step 3. Understanding barriers to BPG implementation. There are 3 major areas that influence BPG implementation, the first being workload. 2. Limited resources. This could include money, finances, budget, staff knowledge and skills, equipment, coworker support, and lack of trained RNAO champions. 3. Organizational constraints, such as high staff turnover, recent or constant leadership change, environment not conducive to best practices, equipment needed for guideline implementation is not available, and limited integration of guideline recommendations into organizational structures and processes. These are all valid barriers to change. However, even when these barriers are in place, it doesn't mean BPG implementation initiatives will fail. It is important to weigh the barriers against the facilitators to determine the organization's readiness for change. Barriers could only reduce the likelihood of a change and not the successfulness of a change if appropriate planning is performed. Let's take a closer look at Step 4, Implementation Strategies. As a best practice champion, you will need to encourage and support lasting behavior change by using multiple strategies. In fact, the more influencers for change you put in place, the higher the likelihood of successful implementation. There are a few strategies that one may consider when implementing a BPG. Leadership, which means at all levels of the organization. Change should be reflected in the mission, values, behaviors, and attitudes of all leaders throughout the organization. Embedding change into policies, processes, and documentation. This shows that the change is well planned and here to stay. Audit and feedback, such as through chart audits and ongoing evaluation. Local opinion leaders, champions like yourself. These are practice champions and resources at an organizational level who can influence colleagues' knowledge and practice. Local consensus means polling staff to gauge acceptance or attitudes regarding proposed practice change. Education. Resources, for example, handouts, should be created to support or reinforce other education initiatives. Multiple and multimodal approaches, which combine strategies such as audit and feedback, education, reminders, local consensus processes, and targeted marketing, help people stay on track. It takes time to make practice change. Work hard will eventually pay off. As a rule of thumb, always start with a vision and pilot where success is achievable. Visit the plan regularly, and if you hit a wall, step back temporarily and leverage on resources and other initiatives. Step 5. Dissemination and sustainability. It's also just as important to monitor how new BPG recommendations are being used in a practice setting before, during, and after implementation, and to evaluate the outcomes or impact of the change. This information is used to measure effectiveness and to inform future developments. And some examples of this may be through chart audits, observation at point of care, directly asking clients about their healthcare encounters, quality indicators, satisfaction scores, and/or pre-test, post-test measures. RNAO uses the following categories of indicators to measure progress: structural indicators, process indicators, and outcome indicators. Structural indicators refer to the supports and resources that are provided by the organization to enable successful BPG implementation. They are supports that enable healthcare providers to deliver quality care. Some examples of structure indicators are perhaps material resources such as equipment, human resources such as staffing and skill mix change, or organizational structure such as layout changes or policy changes. Process indicators evaluate the actions and whether BPG recommendations directed at the education, training, and practices of healthcare providers have been implemented. Process indicators point to what is actually being done in giving and receiving care, and how the system has changed to support patient care. Outcome indicators attempt to describe the effects of implemented care changes on the health status of patients and/or clients, care delivery by the provider, and the resulting impact on the organization or broader system. Always remember sustainability. The degree to which an innovation continues to be used after initial efforts to secure its adoption are completed. The two most effective strategies for project sustainability is continuous reflective practice and organizational leadership, both of which should be considered at the stage of gap analysis. See, we have gone full circle and gone back to gap analysis. That wraps it up in terms of this presentation. Remember, you are important. You are leaders who have a large part to play in championing changes related to best practice guidelines.